Hello and welcome to our very second ever TB Ed Talk, a series from TB Fighters where each month we sit down with experts in the world of TB and learn about the thing that they're the expert in, and we ask them questions. My name is Tori. I will be your host tonight, and with me here is our amazing guest. She has worked for more than 25 years to increase access to high-quality, appropriate treatment for TB, especially for drug-resistant TB. Together with collaborators and mentees around the world, she leverages research, training, policy, programmatic support, activism, and advocacy to advance global health equity. She is a professor of global health and social medicine at Harvard Medical School and a senior research associate at Partners in Health and an associate epidemiologist in the Division of Global Health Equity at Brigham and Women's Hospital. And she's also a notable exception to the rule, don't meet your heroes. Please join me in welcoming Dr. Carole Mitnick.
Thanks so much, Tori, and thank you, JD and Melody and everyone else in the background for making this possible. I'm delighted to be here with you today, and I am going to try to share my slides. See how that goes.
1 second, I have a couple of quick announcements before we go into slide share.
Please go ahead.
Before Carole gets started, if this is your first time joining us, I'm just going to go quickly over how it works. If you have questions for her during the presentation, put them in the YouTube chat and our amazing mods are going to get them over to us. And also keep an eye on the chat for some polls and things that might come up. When Carole's done, we're going to ask a mix of our live and pre-submitted questions. And we'll close out by telling you who our next speaker is going to be and sharing a few other upcoming events. And the last thing before we get started, it's super important. So we wanted to get it up front to catch the people who don't watch until the end. For our US audience right now, the US government is withholding billions of dollars in funds that have already been approved by US Congress, causing severe cuts to programs like PEPFAR and Global Fund funded programs. If you have 5 minutes at any point, please use them to call your members of Congress and ask them to pressure OMB and the State Department to release the funds. There's a link on how to do that in the video description, the doobly-doo, and it is incredibly important, so we appreciate everybody who's called and everyone who will call. And now I will turn it over to Carole.
Great. Thanks, Tori. Such any important announcement, and especially in this week when we are honoring and celebrating Paul Farmer's birthday, to do this in his memory. So thank you. Now I'm going to share my slides.
Now we're going to share the screen.
All right. Is that working okay? Great. Great. So thanks again for the opportunity and for the introduction. And it feels a little bit perverse that I have truly spent my whole adult life working on tuberculosis and multi-drug resistant tuberculosis. And I'm going to talk tonight about something in which I'm a little bit much more of a novice, but which is incredibly important, and that is the phenomenon of post-tuberculosis lung disease. So what I'm going to do is walk through some definitions and a little what we know about the magnitude of the problem of what we call it PTLD, or post-TB lung disease. I'll share the boundaries of our understanding of post-TB lung disease. And then I'm going to go dig deep into a little tiny pilot study that we did with our partners in Peru at Socios En Salud, talk about why Peru was such a good place for this study, what we learned, and what it has meant for care for people with post-TB lung disease in Peru. And then we'll broaden it again, talk a little bit about my hopes in this space, and maybe some ideas of how folks can get involved in realizing those hopes. So here's just a question to get some feedback from folks here. Had you heard about post-TB lung disease or sequela of TB before you saw a TB Ed Talk advertisement on that subject? So I think this is in a Slido poll as a word cloud. Oh no, sorry, this is just a survey question. Excuse me.
This is in the YouTube chat, and I'm looking at it now, and it's showing that the majority of people had not heard before
okay.
This. About 70% answered no.
Okay, very helpful. Thank you. I also came to an awareness about this quite late, and we can talk about that. Oops, I'm going backwards. Okay, so then this one is in the Slido, and geez, sorry. Let me. So this is the just intended to be a word cloud. I don't know that I can show results of that word cloud. If other people can see it. But that is the question. What words come to mind when you hear the term post-TB lung disease? I know it's new for many of you, but what comes to mind?
And the link for that is in the chat.
And Tori, can you see the word cloud? I don't know, here, it looks like it may be coming up here.
I believe it will be coming up there. Okay. And if not, I have seen it in one of the back-end answers, so I can just share that one. We are learning as we go.
Yep. I see that people are typing, so thank you. There we go.
Yep.
Well done.
I clicked the show results button. Should have guessed.
Brilliant. Great. So lung damage seems to be a very frequently occurring one. Holes in lungs, shortness of breath, really important. The symptoms as well as kind of the physiologic phenomena, COPD or chronic obstructive pulmonary disease. Unnecessary. Love it. Love it. Doesn't have to be that way. Yep, the chronic nature, the idea that this is not a short-term thing, and then some of the impacts on people's lives, the inability to work. These are so great. A non-tuberculosis mycobacteria infection. So Mycobacterium tuberculosis is not the only mycobacterium. There are others. What else do we see? Bronchiectasis kicks you when you are already down. Indeed. This is great. Thank you guys and fear of TB recurrence. I'm going to talk about that a little bit as well. So for people who had never heard of it before, you've already done your homework, and I'm really grateful for that. Okay, so let me go back to the slides. So what is post-TB lung disease? So it is the definition that we use is a consensus definition that was really kind of made up by a bunch of experts a few years ago because there was no single answer in this space. And that answer now is evidence of chronic respiratory abnormality with or without symptoms and attributable at least in part to previous tuberculosis. And it can be, it's a very broad set of findings and places where the harms can occur and ways in which the harms can occur. So they can occur in the airways. You can have constricted or blocked airways, so making it hard to breathe. You can have a thickening or blocking of the airways and also of the lung tissue, a scarring of the lung tissue, also known as the parenchyma, and that prevents the lungs from sending oxygen into the blood and getting carbon dioxide out of the blood. The pleura it's the membrane that kind of wraps around the lungs. And if there's pleural damage, it makes it hard and painful to breathe because there's kind of more resistance than there would be normally. And then it can also cause some cardiac related harm where it can make it harder for blood to pass through, particularly the right side of the heart. So it's quite a wide range of conditions, which is one of the huge challenges in both studying it and doing anything about it. So how many people actually experience post-TB lung disease? Well, my first answer to that is going to be, we don't really know because we don't routinely look. What we know is from individual studies, usually in a single place, usually a kind of selected and probably biased population. And then in each different study, different tools are used to measure that post-TB lung disease. So with that huge caveat, I'm going to tell you that the current estimates are that there are about 155 million people alive today who have had TB previously. And that about 60% of those, as represented by the little orange people here, about 60% of those may have some sort of post-TB lung abnormality. That's a really big number. 60% of 155 million, for those of you scoring at home, about 90 million people, maybe. And so even if that's an overestimate, even if it's half that number, we're still talking about 45 million people. So it's an enormous, enormous problem, and we really need to get more of a handle on it, because without addressing it, people are likely to continue to suffer. So how do we quantify the impact of post-TB lung disease on people's lives? So this is going to be from the perspective more of an economist or modeler's view. And I would really love to hear if people in the audience feel comfortable sharing what their lived experience is like, because this is a little sterile. But this is the way that people often think about it in public health and in economics. So there is this unit of measurement called a DALY, or a disability adjusted life year, which John Green talked about quite a bit in his book. And it is composed of two parts: of years that are lived with some sort of impairment. So in this case, like a lung impairment, and years lived that are shorter than what was expected. And so it is that combination of what was the expected healthy life, so going all the way from infancy to adulthood, and these little lighter areas are areas of some sort of disease. So it's not just TB or post-TB lung disease, but it could be flu, it could be mono, who knows, could be cancer. But so the idea is that there was an expected lifespan, and that there is a portion of that expected healthy lifespan that is reduced either to the post-TB lung disease disability or actual early death. And about 50% of the DALYs from TB are actually occurring in the post-TB period. So this is a huge, huge impact. And it's not terribly surprising when you think about the fact that in most of the world, the people who get TB are often young adults. And so there's a long period of life after their course of TB. And if they're not getting appropriate treatment for these impairments, that's going to lead to a lot of time with the impairment. Yeah, there's what I said before. It's almost 50% of the DALYs are attributed to the post-TB period. So that's like I said, kind of the economist's perspective on this, but I think other perspectives might be more meaningful to many of us. So how do we think about the risk framework for post-TB lung disease? What makes some people more susceptible to it, some people less susceptible to it, and how does it all come together? So I adapted this from an article in an academic journal from 2024. And one of the ways I adapted it was by adding the structures and systems part. So as Tori said, I've worked really closely with PIH, again, for pretty much my whole adult life. And so I've been very influenced by acknowledging that systems and structures really underlie all of these individual level risks. And it's not realistic to think we're going to do something about this major issue if we don't also do something about the structures that increase risk. But generally speaking, the systems can put pressure on the actual bug, the Mycobacterium tuberculosis, on the environment in which people are living, and on the individual themselves, and in several different ways. So for example, the environment, it could be the amount of smoking in the environment, that could be kind of the occupational hazards, say for minors who have extra exposure, or if you live in a polluted area. I would also add community prevalence of TB as an environmental factor. One of the things I forgot to say before, I apologize, is that among the conditions that are considered post-TB lung disease, I consider another bout of TB as a post-TB lung disease, because people who have had TB are at much higher risk of a second case of TB. And then also there are other infectious diseases that people who have had TB are more susceptible to. So there are some fungus that really like those cavities in the lungs after TB. So in order to try to do something about post-TB lung disease, we really need to kind of break one or more of these chains. So if we focus on, say, antimicrobial resistance in the hopes that people will get diagnosed faster, treated faster, there won't be as much of a delay. Perhaps there won't be as much lung damage occurring while they're waiting for proper treatment. Smoking is another big one that we do see a much higher risk of post-TB lung disease and other non-TB related lung disease among people who have a history of smoking. Thinking about inadequate treatment, again, that could be related to the resistance. It could also be not in places where the latest regimens aren't being offered, and trying to change that clinical practice so that people are getting the best treatment possible. And then obviously working on the larger structural and systemic factors could really have an impact on multiple of these more individual level risk factors. So how do we know if an individual has or is at risk of PTLD? I've given you kind of the big framework. I've told you about the large numbers. And again, the short answer is that generally we don't, because what we're typically focused on in TB is breaking this chain of transmission. So this kind of fuzzy orange person represents the transmitter, and the focus is to stop them from transmitting their TB to other people. And so we're really not thinking about what happens to people after they stop being a transmitter. We do now, as of 2021, have some new standards that support a strategy for trying to evaluate everybody who finishes TB treatment with a set of tests to really understand who does have post-TB lung disease, and then to be able to look backwards and maybe try to anticipate who's at higher risk. We have a lot of tools and knowledge that could be borrowed from other areas of respiratory disease, of chronic lung disease, like COPD, like emphysema, like bronchiectasis, some of the words that people put up in the word cloud, that we can borrow to try to really amplify our understanding, and the same for tools. And so we can ask a lot more questions, and we can do a lot more tests. And I'm going to talk about some of those questions and tests in a minute. And then we can do a lot more research as well, using this borrowed knowledge and tools, and developing new hypotheses and ideas for how to explore this. So one of the just indications of how little we tend to focus on post-TB lung disease, you can see in the most recent World Health Organization operational handbook on tuberculosis, which was just published earlier this year. And the idea is it's supposed to be a companion guide to the guidelines, and to be much more like operational, much more hands-on. And most countries with high burdens of TB really try to follow WHO guidance very closely. They use it for diagnostics, they use it for treatment regimens, and you can see just from these quotes that I pulled out that they're kind of a lot more hesitant about recommending interventions that would help detect post-TB lung disease than they are about culture, which would tell you whether somebody still has TB at the end of treatment. So the suggestion that it's prudent to do a chest X-ray or post-treatment may be useful when or if it is feasible. So these kinds of caveats that you don't see around culture. This last one actually was really encouraging, that it's speaking to people about the possibility of having some post-TB symptoms or sequela was an encouraging addition this year. So what are some of the diagnostic tools that we might be able to use? And like I said, that we can borrow. We are blazing a new trail in the population we're looking at, but we're not really blazing a new trail in how to diagnose lung disease. There's a lot of experience doing that. So there are, and I also, just as a caveat, I think Tori, your introduction was clear, but I just want to be clear, I am not a clinician. So I am not going to be able to answer detailed questions about these procedures. Maybe there are some online, but when we can certainly get answers if people are curious. So there are just kind of routine clinical tests like, height and weight and your pulse and pulse oximetry readings, clinical examination that physicians can use to try to see your overall health. There are a whole battery of questionnaires that are used for people living with chronic respiratory disease. A very well-known one is called the COPD assessment test. Another one is the Modified Medical Research Council Breathlessness Scale. And I'm going to talk about those a bit more when we talk about the project with Socios. The St. George's Respiratory Questionnaire is one that's been translated and validated in, I think it's over 80 languages now. And then there are general quality of life tools that aren't so focused necessarily on lung health, but on general health and well-being. You can do blood tests to try to understand what other diseases people have. That can be really important to know if somebody has diabetes or if somebody has chronic kidney disease. Those are things that can make them at greater risk. And then there are the lung function tests. And this was an area that was brand new to me when I got into the space of post-TB lung disease. So there's these spirometers, there are lung diffusion tests, there are oscillometers, and basically they're all trying to measure your lung function, measure how much force you have, how much in breathing, how much airflow you have, and they do them in different ways, or they measure that in different ways. For imaging, we have your, basic X-ray that's been around for a really long time. And then there are kind of these super X-rays like computed tomography, which gives you a 3D image. And then that echocardiography or an echocardiogram is actually is how you can tell whether the heart is affected. And it uses sound waves. It's basically a sonogram of the heart. It uses sound waves to see how the blood flow is working. And then there are these what we call functional assessments, which are how far can you walk in 6 minutes? How many times can you stand up and sit down in a minute? For those who grew up in the US, at least in my era, I don't even know if it still happens, there were the physical fitness tests, and one of them was the shuttle test where you had to run back and forth over a short area and pick up and put down an eraser. That's one of the functional tests done. And then there are much more invasive procedures like a bronchoscopy where you put a scope down the throat to try to get a visual of the airways in the lungs, and you could take samples if need be. And similarly, the right heart catheterization does that for the heart, so you could learn more about any potential heart involvement. So those are that's the universe of tools that we can adopt, but are rarely seen in clinics where TB is treated in most of the world. And again, I think for me, what became clear to me as I was preparing for this is that it really requires a paradigm shift in how we think about TB and thinking not about people with TB as an infectious source, and moving from a kind of disease or infectiousness control centered model to a person-centered model of care. And there are many of these online. I just grabbed this one. I thought it was a nice one that represents some of these ideas of thinking about patient preferences, of trying to coordinate care, of providing information and education, thinking about physical comfort, so kind of quality of life, the continuity and transition, so from TB care to a post-TB care. Oftentimes people's care is just cut off at the end of TB treatment. They don't have bugs in their sputum anymore. They're no longer sort of eligible for care. And then obviously access to care would be a huge issue for really trying to do something about post-TB lung disease. So I want to bring it back to the group a little bit and just ask, there should be a question in the poll in YouTube about what types, is that?
Yep, this one is going to be another question in the Slido. So it will be the same link and it should be visible right as we click on it. So you'll be able to see the results as they come up.
So really just if people feel comfortable sharing anonymously what kinds of respiratory diseases, chronic respiratory diseases are people familiar with in the audience, and either their own or family, friends, anything. Because as you can see, this is a whole universe of diseases. Let's see if I can, oh, look at that.
Yeah, so we should see the results start to come in. We're on a 10-second delay, so we have to give them a second.
Great.
Yeah, telling them about the movie Magic. But while we're waiting for those results to come in, there's a lot of discussion in the chat about a conversation we had last week with the TB survivor, who brought up a lot of these pieces about how the disease is not over when the disease is officially over. And so I think this is resonating with a lot of people coming off of that conversation.
Great, thank you. Yeah. I'm really glad that you had that opportunity, because I'm gonna say that I had worked in TB for probably 20 years before I heard anything more than an anecdotal report by an individual person I had known who had TB, or by a pulmonologist who talked about people coming back. It really was not, it was not part of my education. It was not part of the dogma, because the dogma was so focused on infectiousness.
Right.
So I see a lot of familiarity with COPD, and now growing familiarity with post-TB lung disease. I would expect some folks to have familiarity with asthma in the group.
I can say that I would have voted for asthma and cystic fibrosis as well, and not I still can't pronounce the
bronchiectasis. Yeah.
Bronchiectasis. Okay.
Yeah. I didn't know about bronchiectasis until relatively recently either. Just one of the airway challenges. Okay. So now I'm gonna transition to talking about this study in Peru. We entitled it, post hoc, we entitled it, "I Have to Breathe." That was a quote from one of the participants in the study, really representing their experience with post-TB lung disease. And it was a mixed method study, and I'll talk a little bit about what that means, to assess these attributes. So the feasibility, the acceptability, the cost, and the effectiveness of an intervention for post-TB lung disease. And importantly, it was a pilot. It was tiny, as you'll see. So for those who are not familiar with Peru, I highly recommend going if you have the opportunity. It's a fabulous, super interesting country. And there are about 34 million people in Peru today, about a third of whom live in Lima. Lima has grown rapidly and enormously since the 1980s when there was violence between the government and some of the population and people in the more rural areas. And so people fled to Lima, and basically there wasn't established housing for many people. So people essentially lived in informal settlements, very, very densely populated, kind of like the one you see in the lower left-hand corner of this. There's a lot of inequality in Peru. The Gini coefficient is a very crude measurement of inequality. And so there is a very wealthy population, primarily in Lima, but there's also a lot of both urban and rural poverty in Peru. About or more than 30,000 people each year get TB, and 2/3 of them live in Lima. It's considered one of the high burden countries for multi-drug resistant tuberculosis, and with about 1,500 cases per year. And again, the vast majority of those occur among people living in Lima. Not a lot of smoking, 7% among adults, but relatively high prevalence of asthma in Lima. Lima's quite polluted. It's kind of like Los Angeles for people who know the geography of LA. It has mountains, mountains to the east and the Pacific Ocean to the west. And so pollution gets really trapped in that bowl in between. And Peru, unfortunately, had the distinction of the greatest excess mortality due to the COVID-19 pandemic. And there's still a lot of question about why it was so bad there. Oh, and sorry, this is just showing the kind of range of TB incidents around the country. So the red areas are the highest burdens of TB in metropolitan Lima, and then in the Amazon is where we really see most TB in the country. So for Libre, so Libre, for those who don't speak Spanish, means free. So the idea was to be free of the sequela, was kind of the source of the name. We used the consensus definition I mentioned earlier, so just any chronic respiratory abnormality. There was very little experience with post-TB lung disease in Peru, but as I mentioned, the ability to borrow a lot from other areas. We had done a very small study in a really select population that found 15 to 20% of people had some kind of impairment on spirometry, one of these things that measures your breathing. No guidance for managing post-TB lung disease, for evaluating people, and TB care is extremely decentralized in Peru. So there are thousands of places around the country where people can be diagnosed with TB and receive treatment for TB, which is awesome for making care accessible, but it's hard if you're trying to make changes and implement something new. It means it's got to go. It's got to be very broadly applied. So the objectives of the study were basically to try to kind of simulate what an evaluation would be like if it could happen right after the end of TB treatment. We started in 2022. It was still kind of COVID-y. And so our colleagues at Socios weren't able to do this in the public health facilities, which is where we really wanted to do it. So the best we could do was kind of simulate that. And I'll tell you what I mean by that. And we were just trying to understand what people were experiencing, what kind of treatment they might need, what sort of follow-up, and as I mentioned, evaluate all those attributes of an intervention. So we started by just trying to do broad outreach in areas where we knew there was a lot of TB, where Socios had worked extensively in health facilities, using social media to say, hey, has anybody recently in the last 3 months had a quote unquote successful outcome from their TB treatment? Are they adults? And do they have scores on these instruments that suggest that they actually have symptoms? And I'm going to show you what those instruments are. So this modified medical research council breathlessness scale, it's just this one element, and you just self-evaluate how bad your breathlessness is. So it could be anywhere from I only get breathless with strenuous exercise to a 4, I'm too breathless to leave the house, or I'm breathless when doing some kind of activity that actually doesn't take a lot of strength. And anybody who had a 2 or higher was eligible for this intervention that we were piloting. And then the other score that we used in the screening was this COPD assessment test, or the CAT, where there are what is it, 7 elements? I can't count, 4, 5, 7 elements, and a kind of a Likert scale ranging from 0 to 5. And focused largely on breathlessness and lung experiences. So having a lot of mucus, having a tightness of your chest, being breathless. So some overlap with the MMRC, but a few more questions. And then if you sum the scores, the score from each of these together, and if that total score was 10 or higher, they were also eligible for the intervention. So then we invited them to come to the private clinic that Socios runs. This less than 3 months since the successful end of treatment was the part that was trying to simulate as if people were getting screened right at the end of their TB treatment in a public health facility. This was the best we could do when we could only work in one place. And so at the Socios clinic, they were consented to participate in the study. They did the spirometry test where they blew into the tube to see how much airflow they had. They did this SGRQ, is the St. George's respiratory questionnaire that I mentioned before. It's 50 questions translated into tons of languages. And then this FACTIF-F, again, is something else we borrowed. It's a 40-question questionnaire that's used to assess fatigue in cancer patients. So it has nothing to do with post-TB lung disease at its foundation, but still very useful to try to understand what people are experiencing. And then the sit-to-stand test and the 6-minute walk test. And then we classified people based on their spirometry, using an adaptation of the global obstructive lung disease conventional groupings. So again, borrowing, that's one of my themes, borrow. There's no shame in borrowing. So the first question we kind of asked to classify people was, did they have any, sorry, that should say any impairment, it shouldn't say restriction. Did they have any impairment on their spirometry? And if it was no, then they were considered to be group 0 and they just got pulmonary rehab as their intervention. If they had a mild limitation, that was analogous to group 1, and they got the pulmonary rehab plus a little some inhalers, kind of like what you see people use for asthma, so short-acting airway opening inhalers. And then as you went down the severity path, so people who had moderate airflow limitation, they got a long-acting inhaled treatment, and people who had severe limitations, they got combination treatments of 2 different kinds of long-acting things. And then the pulmonary rehab was just an hour a session. Each session was 1 hour. It was offered twice a week. It was by video. And it was offered over 8 weeks. And it was a combination of some strength training and some breathing exercises and some cardio work. I told you we were interested in acceptability, feasibility, cost, and effectiveness. This is kind of the details of how we did that. So it was a mixed method study. And so we collected both quantitative and qualitative data and very intentionally tried to integrate that data. That's the difference between doing a qual study and a mixed methods study. This is the walk test you can see in the upper right-hand corner. For feasibility, we talked to healthcare workers. We made a video of the intervention and showed it to healthcare workers and asked them what they thought. And then we also costed out the interventions. And for effectiveness, we used all these functional tests and quality of life tests and compared before and after. So the results at baseline, so it was only 40 people. I told you it was small. I didn't lie. They were a little older than TB patients usually are. TB patients are usually median age is like 30-ish. They were not super underweight as TB patients often are. Only a couple had drug-resistant TB. And you can see that in fact, despite the fact that everybody had reported symptoms, only 3 people had any impairment actually on the spirometry. This is, oops, sorry. And that's the sit to stand test in the corner there. I don't expect you guys to know what all this means. These are the X-ray findings. I don't know what they all mean either, but suffice it to say that people had a lot of X-ray findings. So they didn't have abnormalities on spirometry, but they did have symptoms, and they still had a lot of findings on their X-rays, a lot of abnormalities on their X-rays. We found that people found the intervention to be sort of moderately acceptable. In the upper right-hand corner, this is actually, each line represents one of the participants in the intervention, and the yellow boxes are the sessions they weren't able to attend out of the 16, and the green boxes are the ones they were able to attend out of the 16. So you can see people attended about a median of 70% of the 16 sessions. We invited people to participate in the focus group based on trying to get some people who had been able to do a lot of the sessions, some people who were able to do fewer. And here are some of the things that we learned in the focus groups, that people were really struggling now that they were finally able to go back to work after their TB. They were struggling with how to use their time and whether they could spend the time doing the pulmonary rehabilitation or had to do things like take care of their children and go back to work. There were challenges with technology, which I can really respect. They need Melanie for this, in making sure that they could see the therapist and the therapist could see them doing the remote therapy. And then there was this whole sense of isolation that they had experienced during their TB that was really aggravated by doing these remote sessions. Some people said they wanted to go in person. They wanted community. The healthcare workers acknowledged fully that there is no path in the current system to offer treatment for post-TB lung disease. They kind of tell people to just deal with their symptoms was sort of the message at the end of TB treatment. But they also, and they acknowledge that the focus is on ruling out active TB. And they do say that, we develop a relationship with these individuals over their long treatment. And so we would really be the right place to start this kind of post-TB care if people need it, rather than making them start over somewhere else. In terms of effectiveness, and these are tiny sample size, so we do not put a lot of weight on this effectiveness data. Basically, people felt better. So on the self-reported instruments, people reported an improvement on all 3 of those. There was no change in their impairment, and there was no change in these functional tests that we could discern in this small group. Overall, the cost was about $270 for somebody who didn't need the inhaled pharmacotherapy, and then another $145 for the longer acting ones. So not wildly expensive, kind of manageable within the context of the healthcare system in Peru. So we found a lot of stuff on X-ray. There's a lot of lung damage on X-ray. There was some discordance between what people reported and lung function, but the report was more aligned with the X-rays. The intervention overall seemed to be feasible, with some dedicated resources that Socios and our funders put into this, and that acceptability was sort of moderate, as I said, that about 70% completed, and that there would need to be a lot of investments in Peru to make this something that could be more available. All right, I'm going to skip that just to be able to show you where things stand now. So in Peru, they have very cleverly availed of global fund money. So again, Tori, to your earlier point, so there was COVID money. There was a lot of COVID money in Peru, and they had built these COVID rehab centers, these long COVID rehab centers. And so now they've been repurposed for more general pulmonary rehabilitation and some focus on TB. Right now, there are only these three in Lima. And remember, I told you 11 million people live in Lima, and there are 30,000 cases of TB a year. So it's not going to be enough, but it's a good start. And the hope is that that will they'll build on that. The National TB Program has now recommended routine screening for post-TB lung disease, and they're working on trying to formalize a protocol like the one we use to actually offer care to people post TB treatment. And people living with TB in Peru are really asking for these services as well. Next step for us at PIH and Harvard and Socios is a project to really try to get a better handle on how much post-TB lung disease there is in Lima, what's the nature of it, and what are the human and the bug factors that might predispose people to it, and how can we do a better job of diagnosing people with post-TB lung disease. We have not been able to start because of government delays in funding. We did eventually get funding, but now with the government shutdown, that's causing more delays. So we're hopeful to start in 2026. So I think for me, and I would love to hear other people's thoughts on this, I am hoping that where we can go in this space is to obviously understand better what the sources of risk are and how to avert them. The best way to avert post-TB lung disease is to not let TB happen. It's to prevent TB. It's to continue to work on the development of vaccines. It's to continue to offer people preventive therapy so they just never get TB. Then there's what we call secondary prevention. And are there things that we can do during treatment? Are there treatment regimens that might be better suited to preventing like the immune? It's really largely thought to be an immune modulated reaction. So can we minimize the damage that's caused by these immune reactions, either through the TB therapy or through some sort of adjunctive therapy? And there are some trials looking into this. Can we normalize thinking about people over their whole life course and not, as I said before, as just like carriers of TB? And so that people are screened for risk factors for post-TB lung disease at the beginning of treatment. They're screened for sequela at the end of treatment, and they get access to the necessary care on an ongoing basis. We'll come back to that. So here are just some initial thoughts about ways that people might be able to get involved. And this is very early for me, so I welcome your thoughts. What kinds of resources and platforms can we use to really help people who have experienced TB speak more about this, understand what they would call a successful TB outcome. Right now, a successful TB outcome is just no microbiological evidence of the bug anymore, but that's clearly not adequate. You guys are so good at visuals and memes and slogans. Are there things that we can do to try to help, again, normalize this in our discourse? And are there creative partnerships that can help to bring diagnosis and treatment within reach? I've already talked about borrowing from other respiratory diseases quite a bit. We have new technologies that we're using to try to predict TB, like AI applied to chest x-rays or to stethoscope audio files. Maybe those can also help us with post-TB lung disease. And there are really active patient advocacy organizations for like COPD and asthma. Maybe there's some common cause that can be made there. And my last slide is just acknowledging the incredible LIBRE-Post TB team in Lima, a pulmonologist in Australia, Anthony Byrne, who's really taught me most everything I know about post-TB lung disease, another Peruvian pulmonologist on the team, and everyone else. So thank you so much for your time and attention. And I'm happy to hear questions, comments. Thanks.
Yeah. We have a lot of really great questions that have come in, and I think especially this TB fighter group is going to go right after the memes. So please keep a lookout for the best ones. We'll send them over your way. That is one of the areas in which we excel. But we got a lot of really great questions, and I think the one I want to start with focuses on that patient-centered approach really well. And this came up in the chat. It's a question from JJ, and she asks, when designing treatments, particularly for long-term or chronic issues, how do you approach making the interventions as manageable as possible and getting people to keep up with them? This is particularly hard for people with existing disability to then continue to go on and do all these hard things that we think are going to be helpful. So I'll start there.
Yeah. Yeah, I think it's an excellent question. And I think there are probably people in the audience who may be in an even better position than I am to answer that. In this intervention in Peru, I didn't go into a lot of detail other than to say that it was on video. We thought that would be easier so that people didn't have to leave their homes or jobs. To do it, Lima is a massive city and it takes a really long time to travel anywhere. So we thought that virtual would be helpful. We also tried to hold the sessions at different times of day, so to accommodate people for whom maybe morning was better or evening was better or midday was better. And we tried to share reminders with people about it. We gave people credit for data if that was an obstacle. And like, despite all of these enablers, still, the average number of sessions attended was 69%. So I don't think we've cracked that nut yet. And I think it's a huge issue, and it's going to require a diversity of solutions.
Yeah, and I know it's a difficult issue for non-disabled people to come up with ideas of things that will work for disabled people, and so I'm sure that there's a lot of value in that community as well. Maybe did the participants in the study know each other? Were they able to kind of collaborate and build community amongst themselves, or were they kind of individual about it?
No, I think mostly they didn't know each other. I think it was really just if they got to know each other on screen doing their exercises, or they happened to have their study visit at the same time. And that was, like I said, that was one of the things that we learned from at least a couple of the participants, is that they were keen to develop community.
Yeah. And that is such a big piece of it. I think we see that in our survivor community here as well. Just making things a little bit more, there's somebody there, right? The community makes a big difference. We have another question in here from our nerd fighter Llama, who, if it is the Llama, I think it is another doctor. And she asks, to me, the idea of having less toxic treatments and treating sequela represents a new phase in TB treatment. It took us too long to get here, but do you also find that hopeful? Okay.
Do I find it hopeful?
Yes.
Yeah, I do. I mean, you're absolutely right. It has taken us so long to get new TB treatments, but the pipeline of new TB treatments is pretty robust. And so I do think there's been a shift. We have often talked about people who work in TB kind of operating from a paradigm of scarcity and thinking that we have this little teeny tiny pool of resources and we can't be ambitious. We have to think small. And I do think that's changed some. That notion still permeates many discussions, but it's not as common as it used to be. And so I think in parallel, there are these trials, like I said, of immune modulators being given during TB treatment that might reduce the risk of post-TB lung disease afterwards. And so I do think there are people who are really invested in this. And if we can actually continue to fund good science in this country, we could make some progress there.
And on a kind of related note there, what's the process for operationalizing more testing and treatment for PTLD? And what kind of resources and advocacy are needed in this space? That's a question from Catherine.
Super question, Catherine. Thank you. I think that was exactly what we were trying to do with Libre, is just, develop a little protocol and see like how hard was it to implement? What would it take to put this in place? And I think we're still at the infancy here. That was one example. We don't even really know if that's the right intervention. We were just borrowing from other chronic respiratory diseases and trying to provide that and make it something manageable. But I think these packages are going to be really helpful, especially if we are hoping to make care for post-TB lung disease available everywhere care for TB is. That I think having these little packages and having really good referral systems too for when this kind of more modest intervention is not enough. That's going to be a critically important part of it. And I think we're going to have some more intellectual property struggles on our hands. Like, how do we get our hands on cheaper versions of these inhaled pharmacotherapies? And if they're, are developers going to claim TB or post-TB lung disease as a new indication as a way to try to extend exclusivity? That could be something that we have to look out for in the future.
We will be on notice for that as well. It's another area where we excel with the memes. Exactly. And there's a couple of other really good ones, and I know we're running short on time, but one of the questions, because we've talked so much about putting the patients first here, is from Catherine again. It might be the same Catherine, it might be a different Catherine, but she asks that what are the most significant impacts on a patient's day-to-day lives from post-TB lung disease?
Is it possible for people to respond to that in the chat? I really feel like I'm not the right person.
What people could. And this can be one, and I know you mentioned when we were talking potentially more conversations with TB survivors on that. So if that
exactly, yeah. Thank you for reminding me, Tori. Yeah, I was speaking to Kate O'Brien about trying to do kind of a version of this discussion for people who have questions about their own experience, and making sure we have a clinician involved in that conversation as well.
That's great. And we did get some great questions from a TB survivor submitted in advance. So I do just want to say we'll share those over for that conversation with the right people involved. And those questions will not go unnoticed.
Great.
We have we have so many great questions in here. One is, has there been much data on pediatrics where the children are treated for TB before reaching full lung development? Are their outcomes similar?
It's such a good question. Yeah, there is data that kids suffer from post-TB lung disease as well. There's an amazing birth cohort, not having anything to do with TB, but really just following these children from actually in utero and then birth, and in South Africa, and a substantial proportion got TB, and a substantial subset of them have sequela. My colleague Sylvia Chang, who's worked with Socios as well, is doing some work on TB and post-TB in adolescents. And even when lungs aren't fully developed and there's that opportunity for further development, we're still seeing really important compromise.
Yeah, I wish the answer was no, it's perfect.
Exactly. Exactly. I wish it were too.
Yeah. Okay, I think we have time, maybe one, maybe two more. So Benjamin asks that most diseases causing pulmonary inflammation have long-term and cumulative detrimental effects upon lung health and function. Are there any features of PTLD that are unique and not seen in other chronic lung diseases?
Really good question, Benjamin. And I don't think we know the answer to that yet. Because right now what we're calling post-TB lung disease is just this constellation of so many different conditions. that we have not been able to tease apart yet, whether there are truly unique attributes or it's, kind of we've seen it all before. Stay tuned.
Yeah, we are absolutely tuned. We can't wait for you to come and give us an update on this eventually. We're always happy. All right, one more question from JJ. How does the stigma around TB impact the development and implementation for interventions on post-TB lung disease?
I think like the disease, the stigma is lasting. That is what I have heard from. I've heard that from TB survivors. I've heard it from providers that it can be a deterrent to seeking help. There's also, I suppose it could also be hard to separate the stigma from what we were talking about earlier when you're just so relieved to be done with your TB treatment and you want to go on with your life. The idea of continuing to revisit it by saying you're going to do pulmonary rehab or whatever the regimen is, I think is part of it. But I have definitely heard from people who have survived TB and also providers that the stigma plays into a willingness to seek post-TB lung care.
Yeah, which makes sense. And it's a little bit of a double-edged sword from what we've heard from people as well, right? The disease is over. People think, okay, you should be better now. You should be able to get back to your life, but you're still feeling it, but you feel like it should be over. And so it becomes one of those cycles.
Exactly. Which can aggravate perhaps self-stigma. That you feel like you're doing something wrong if you're not feeling better at that, when that's not the case.
Right.
That's the
right. And when you've been away from baseline for so long, you're like, maybe this is just how I feel. Maybe this is actually normal and the check engine light is not on.
Right. And when doctors are telling you to just kind of deal with it.
Yeah. You're like, oh, I am fine now. Okay. My bad. Didn't know that.
Right.
Yeah. Well, Carole, thank you so much. I have one last question that we've liked to end on. I would say always, but we're 2 of 2, which is everything is really, really bad right now in all contexts. But what are some things that are kind of still giving you hope in this space and keeping you going? We're big on hope over here.
Yeah, I think honestly, it's my colleagues, it's my PIH colleagues around the world who know that despair is not an option, that cynicism is not an option, that people need us to remain in solidarity, to make sure we're listening to them and doing anything we can for their voices to be heard. And they're still every day really committed to the notion of a preferential option for the poor. And that really does give me hope. These people who sometimes call themselves TB ninjas or I forget what one of the other ones is, but TB warriors, just knowing that we are in community with people who are really, really invested in this makes it easier to keep going. And the progress and the progress that we did make this year after the Hill Day in preserving quite a bit of TB funding, I think that is an extraordinary reflection of what this extraordinary group has done, and that also gives me hope.
It is hard to remember that actually this does work, right? All the calls, all the emails. It's hard to see when you're just one person doing it, but I believe we actually have one of our group advocacy sessions right after this, where a bunch of us just get on a Google Meet and we all call together so that we have that community around us while we do it. That is awesome. One thing that we love, is making it so much better. Carole, thank you so much for your time and for coming out here and everything that you've done for us. As a TB fighter community, we've learned so much from you. You're really one of our favorite people, and we are so grateful that you took this time with us tonight.
Thank you, the feeling is very mutual, so I really appreciate it.
Yeah, I'm hearing that the memes are already rolling in, so that is great news. I have a couple quick announcements, and then I will let you go. So it sounds like we've got some calling and advocacy sessions coming up. Our mods will put details for those in the chat. We are also, our TB Readers Book Club is starting the Black Angels soon, so you can check out our website for more information on how to get involved with our book club. That's what I'm very excited for. We have, as we already mentioned, our call to action for PEPFAR. If you haven't made your calls today, please get on that. You can make them every day through the tool. It's very, very straightforward. And then our last big moment is announcing who our next talk is going to be. So our next TB Ed talk is unfortunately not going to be in November. It is going to be on December 2nd, and it is going to be Stijn Deborgrave, hopefully I was in the ballpark of pronunciation on that, from MSF, speaking about pediatric TB. And the reason we're doing this in December and not in November is because Stijn is speaking with John on his channel with a panel of other doctors, and I believe the parent of a pediatric TB survivor. And they're doing a panel discussion. So we want to give that space and then build on that. And also everyone's at the conference in Copenhagen at the end of November. So no one, everyone's busy. And we'll have a lot of learnings out of that. So that is going to be on December 2nd at 10:30 a.m. Eastern. And we're really excited for that conversation. We're going to learn a ton. And since we're missing out on November, we might have a secret second exciting thing happening in December as well. So that will be great. So again, thank you so much. Thanks to our mods and everybody helping out in the chat, Melody running the video, all of this. We appreciate you all so much. And as they say in our hometown, don't forget to be awesome.
Thank you.